Right, Quisha, Justin, Leslie. Right. We'll give people a couple more minutes to continue typing, but we thank you all for coming today once again, and thank you. Hey, Gail, welcome, Gail. We thank you all for sharing your information in the chat. We now know who is in the room. It's back to you, Ashley, when you're ready. I don't know if people are putting their favorite event, but I know we've been doing that a lot of that in meetings. So, toward the barbecue.
All right, great. Well, again, thanks everybody for being here. It's lovely to see lots of familiar, friendly faces as well as some new friends. So just to give you a quick overview of what we are going to be talking about today. First, we are going to have a national policy briefing from our colleague, Justin Mendoza, who's the advocacy lead over at Partners in Health. We know that there are a lot of policies that are really important to community health workers and CHW allies that are not necessarily focused exclusively on the CHW workforce, but rather larger issues. So Justin has generously volunteered to come and talk to us a little bit about those today. In several of our last meetings, we've had requests for more information about the ever-changing landscape of Medicaid state plan amendments and status of CHW certification. So our colleague Carl Rush is going to do an update on that today. We're also going to go over a relatively new process that NACHW has implemented to receive requests for reviews of various types of policy documents. So we'll show you what that looks like. We'll talk about a couple resources and have a discussion, and then we will go into announcements. So that's the overview of our session today. So with that, I'm going to turn it over to Justin. I believe that he has slides he'd like to share. Is that right? Okay, cool. I will stop sharing mine then. And Justin, we will let you take it away when you're ready.
I can do a brief introduction, Justin. You may have it in your slide, but you've already heard from Master Justin Mendoza. He's the advocacy lead at Partners in Health, United States, where he leads the coalition efforts, government affairs work, and policy development work focused on health equity through advancing the role of community health workers in the United States and securing increased public health investment. He holds MPH from Yale University in health policy and studied biomedical sciences at Central Michigan University. Justin, the microphone is yours.
Wonderful. Thank you so much, Darrell, and thank you for having me here with the NACHW community. I'm excited, and we're officially members, I think, as of a month ago. So we're excited to be here among fellow members of NACHW as well. So I'll go ahead and just jump right in to start with, and this is a little bit just a touch outdated because we've seen some increases in workforce that we'll talk about, but this won't be news to anyone on this call. But we started to get involved at Partners in Health in really focusing on community health workers and public health investments in the US, because we realized while we were working on COVID-19 response that one of the big reasons that the pandemic was such a huge burden on communities across the US, particularly communities of color and communities that are low income and rural, is that we failed to have proper long-term sustained investments in community health and public health programs. And so we know that the workforce has been cut by more than half if you're looking at just traditional public health roles and excluding community health workers, from 500,000 to under 200,000 jobs since 1980. And these roles are even, and there are even fewer when it comes to thinking about community health workers and doulas and other positions that are truly embedded in the community. And so we've been trying to work with community-based organizations and lots of other folks to push back and use this moment of COVID response and other things to to try to really get some of those investments that folks have been asking for years. And so today there's a couple things I wanted to talk to you about. First is just a quick catch up to where we are right now in terms of the federal policy landscape, and then a moment of opportunity that we have in front of us that's the prognosis is kind of mixed. So we'll talk about it really quick. But the first one I wanted to point out is, in case folks haven't heard about this, the American Rescue Plan Act, which passed way back in 2021. And it's still working, still coming together in terms of the funding going out the door. And let me open the chat in case anyone asks any questions there. I'll move it off to the side. But the American Rescue Plan Act has been law since then. And what we were able to do in coalition with NACHW and with many other folks in the CHW space is really push for at least some investments in the community health worker workforce as a response to COVID in those days. And this is a huge breakdown.
Hey, you get it?
Oh yeah, we did. We got some of it.
Another too, shit.
Oh. Awesome. But
Yes.
Just want to remind everybody to please mute if you're not speaking.
Wonderful, thank you, Ashley. But yeah, so this is a really quick snapshot, and I know this is a lot of information on a slide, so don't worry, I'm going to send these slides out after. But the main thing here are those first two lines. The Health Research and Service Administration, or Health Research and Services Administration, rather, out of this multi-billion-dollar package, this huge collection of workforce dollars, was granted about $250 million. And this was an estimate, it's slightly lower than that, like 241, to give out to community-based organizations. And they split it up into two buckets. One was where pass-through organizations, larger organizations like Partners in Health, would work with community-based organizations on vaccine outreach, paying CHWs to do trusted messaging work, and really trying to figure out resources and support that folks needed in response to COVID in the second half of 2021 and the early part of 2022. That was a 8-month-long grant period. It was way too quick, and we have a lot of critiques for how it rolled out, but that was something that came out of the American Rescue Plan. And then the other part was more direct funding for some smaller community-based organizations who employ CHWs, a few federally qualified health centers, and community-based organizations like El Sol Neighborhood Education Center out of California, who were able to be recipients on these for $1 million grants for 1 year of work, and those are still ongoing. Beyond that, the rest of the money that was rolled out in big mixed ways, mostly to health departments through the CDC. Some of it actually went to AmeriCorps, though I'm proud to say that we convinced them to change the way that AmeriCorps was being funded so that it wouldn't be, initially they wanted to give AmeriCorps billions upon billions of dollars. And we as a coalition talked folks down to less than $500,000 or $500 million, because AmeriCorps, although it is a fine program in many ways, doesn't train community health workers, doesn't give folks that kind of real embedded experience that we all know is so important. But all of that being said, this is just a quick snapshot. And then this was another piece of it. This one has nothing to do with workforce. None of the money on this page went to community health workers, but you can see almost $230 billion went out for public health interventions and funding in the American Rescue Plan. Now, I raise all of this because we just got an update earlier this week from the White House on where we're at with all of the public health workforce funding in the American Rescue Plan. And the top line they gave is that $40 billion has gone out the door already. Out of that, really 220 plus the 8 billion, so 240 almost $billion. That's in the American Rescue Plan. And The top one here is, and I went through their announcement and found every mention of community health workers so that we could see those. And it's 4 pieces. That's it. Out of this $40 billion that have gone out the door, 4 pieces are mentioned. And one of those is the CDC, still working on this, but the CDC is granting $3 billion in public health workforce funding. And I believe right now health departments can apply for that funding. It flows through health departments. It doesn't flow directly to organizations, but those funds will help health departments that have employed CHWs on a temporary basis to keep those CHWs for a little bit longer. Some of them contracted out, like in the state of North Carolina, and others, like in Los Angeles County, just hired their own CHWs with earlier funding, and it lets them extend it. Then they talked about some of those large programs like the Rise Together initiative to mobilize CHWs in counties all over the country. They didn't get into the details of how much money that was, but just listed it. One that I thought was really interesting was in New York City. The city has decided to take public health core money from the American Rescue Plan and specifically hire community health workers and work with some of the local organizations in the city. I don't know all of the details about that, but I do know that it's focused on racial equity. So it was one that was highlighted in this. It's only $50 million. So it's, I mean, which, you know, I feel silly saying only $50 million, but on the scale of $40 billion, we're talking about very, very little. And then finally, they mentioned by name the Association of Asian American and Pacific Islander Community Health Organizations having a community health workforce collaborative of 250 plus CHWs in 12 states across the country, focused specifically on serving communities that speak languages and need services and cultural competency that comes from Asian American and Pacific Islander groups. And so they put all of this in here just to kind of highlight where we're at right now. But you might be getting the sense already from this. We look at this and think, okay, it's nice, it's something, but it's nowhere near enough in terms of a sustained community health worker role, expanded roles, expanded services, and more embedding into community. And also, some parts of this are very medicalized. So it's very much tied to CHWs employed at federally qualified health centers, or very tied to CHWs getting billed services for only those kind of medical pieces. And I'm preaching to the choir to you all, so I'm not going to ramble about that, but just saying this isn't perfect. And actually, no, these are not the CRR grants. These ones are brand new funding that we just got the notice for. I can forward it on to the list to make sure that everyone gets it. And I didn't write that down. So we'll skip the political context slide, but well, actually, I'll explain the political context, but I didn't actually make that slide. I apologize for that. But the main reason the American Rescue Plan is important to look at is it passed and was very contentious, right? It was led by Democratic leadership in the House and the Senate. They used the reconciliation process, which mainly is only important because it lets a bill pass the Senate with only 51 votes. Otherwise, you have to reach 60 votes. And with how polarized the US Senate is right now, there's almost no way to count to 60 votes on really anything. The only thing we've passed with 60 votes that was substantial this year is funding for Ukraine, and it was only the first batch of funding. And that was an immediate response to Russia's invasion. So politically, it's almost impossible to get that done. So the American Rescue Plan was passed under this 51 vote process, which created some problems because it has to be about the budget. So you couldn't put much policy into it. We couldn't get the Senate to direct how the funds were going to be allocated. It ended up being punted to the CDC or HRSA to use their existing systems of allocation. So even though we and NACHW and many others pointed out to the agencies that there were problems with how they allocate the funds. We couldn't get them to change it because they didn't have the authority to do so in the bill. We saw that they weren't able to include new definitions for a community health worker, for instance. So it's still using the old CDC definition, which isn't as encompassing. So back then, we started talking, many organizations started talking with Senator Bob Casey about the Building a Sustainable Workforce for Healthy, not Health, Healthy Communities Act. And this bill was initially supposed to be kind of almost everything we'd want in terms of federal CHW policy. But in the end, we have a bill that has these strengths and weaknesses. It creates a better explanation of services than existing law at the CDC. And we'll talk about what that law is in a second. It adds some capacity building pieces. It doesn't limit services to one disease, but all of those, the weaknesses are still there. Limited to medically underserved areas. I mean, that one's a really big one. It's a definition that mostly works to start getting to equity, but it's not as good as something like a social vulnerability index, which might give us more information and more direct targeting towards communities that really need support and CHWs to be uplifted. It's short-term funding, and it doesn't give us new funding, which that one's critical because if you look at CDC programs and CHW programs, one thing we all point out is there's just not enough money flowing into these programs to truly sustain or expand where we need to. And so this bill, the Building a Sustainable Workforce for Healthy Communities Act, here's the general timeline. It was introduced in July 2021, or drafted, sorry, in July 2021. And that version never saw the light of day. But in that version, it included $8 billion in funding. And then it included a section on Medicaid that would make state plan amendments even easier to achieve. And I know that we'll get a good briefing on those later, so I won't even touch the policy there. But it had some tweaks, which were beneficial. But because of how polarized the Senate is, how polarized the House is, a version of the bill was introduced with the bipartisan Prevent Pandemics Act on January 11th of this year, which doesn't include those two key pieces, nothing about Medicaid and no one-time funding. So it just reauthorized existing CDC programs for community health workers. And it changed the definitions, changed some of the policy, gave us some of the tweaks that are potentially better, but no new funding and no Medicaid tweaks. So it doesn't give sustained funding either. That version of the bill was lumped into the Prevent Pandemics Act, which is a bigger bill, and passed in a bipartisan way out of a committee. What that means is it still has to go to the Senate floor, and we still need the House to work on it at all at this point in February when it makes it out of committee. So finally, months later, in June, the House introduced the exact same bill, copy and pasted it, and introduced it in the House. And there was a hearing in late June. I think it was actually June 27th. And yeah, it was exactly. But on June 27th, that bill got a hearing. They had one CHW witness from Washington State who did a wonderful job explaining both strengths and weaknesses in the language as it was, and calling for sustained funding. Now we're just waiting. There should be a markup scheduled sometime this fall where they'll actually debate tweaks to the language. And then if it passes there and then passes both the House and the Senate floor, then it would go to the president's desk to be signed. There's a very narrow possibility that that happens, but it's still out there. So these slides kind of go into what the bill actually does, but I know that NACHW was closely involved in this. NACHW put together a really excellent letter explaining to the Casey team what should have been tweaked in the bill. Unfortunately, by the time we sent in those letters, like NACHW sent one, we sent one, a group called Penn Center sent one, and the Civil Rights Corps also sent one, amplifying similar asks. The Senate had already come to an agreement. So we sent these letters. We knew even when sending them that the Senate had already come to an agreement, but we were all kind of just frustrated they didn't ask us for a final say on the text before they introduced the bipartisan version of the bill. But basically it does these things. It gives these agencies the ability to recruit, hire, and train CHWs, and it supports a ton of functions. And I copied and pasted in some of the language, but taking out some of the whereas and such as and things like that. So it's a little bit easier just to read it as a normal sentence. But it also importantly drew in some priorities in terms of communities that have to be served and language and cultural context. So it really does improve what CDC had before, which is like 2 paragraphs describing the basics of what a CHW is without even touching cultural competency. Yeah, I'll definitely share these slides, Carol. And then it also encouraged all of these things, grantees to work with academic institutions, and importantly, it didn't require this, but only encouraged it, which we find important because we've worked with CHW organizations and academic centers in some states where the academic centers aren't really that interested in contributing. And so we're happy that it wasn't required. It also required a report back to Congress. It defined eligibility for who can get funding. And the cool thing there that we thought was a win was that community-based organizations are listed as one of the eligible entities alongside a number of other organizations or consortiums. So you could imagine a CHW association at the state level could be an eligible entity for these grants. So it is good in terms of that. You could actually go, hey, North Carolina CHW Association is going to apply for this if this bill were to become law. So I kind of covered this before and I put this in a weird spot in the slides, but basically February, we all sent those letters. Everything was rejected from our suggestions so that it can move through a bipartisan process. Then we began talking with Representative Ruiz's office about the introduction. They finally introduced it, and that sentence there is kind of important. In June, when Ruiz introduced the bill, they were trying to get bipartisan support so that just like in the Senate, it would fly through a committee and make the process easier. But they weren't able to get any Republicans in the US House to sign on to the bill. And there are a few different reasons for that. Some of it's just partisan politics in an election year. But one of the reasons is because there's a Republican-led bill that just authorizes the currently existing CDC program. And they're both sit on the same committee. So they just kind of didn't come together. But yeah, so that's the big piece there. But in the end, where we're at now is we're kind of in this waiting period to see when this actual Ruiz bill will come up for tweaks, and that gives us a window of opportunity to send in letters to make voices heard from CHWs and to try to get things into the Democrat-led bill in the House so that we can see if we can push the Senate bill to get any better as well. My basic synopsis is that the bill is okay, and that's not my email, apologies, but that the bill is okay right now, but could be a lot stronger, could be led more by CHW voices. And the House bill is our best bet to get any of those tweaks in there. Though, because it's an election year, I actually think it's not likely that this year this passes at all, which is not what I was hoping to report to you all today, but it's kind of where we're at. I'll stop screen sharing and happy to take any questions, but I think I might have gone around.
We've got a fair bit of time for questions. So if anyone would like to come off mute and ask a question of Justin, please feel free to do so, or feel free, if it's easier, put it in the chat and we can certainly read it out.
I just want to thank Justin while we wait for comments to come. this was great. This was so good to hear some of those updates because of all the work that got put in. It's sad that a very detailed, review of the legislation and comments that went to the bridge to nowhere. But one thing you said was about this window of opportunity coming up, but that not a lot of hope that it'll pass. Should we still go all out, mobilization, full-fledged, when that window opens, get everybody we can, just in prep for whether it does pass or doesn't, so that we can know that we've done the right thing by the workforce, but also to kind of be a test run for the next go-round? What's your thoughts on that?
Absolutely. I think that's essential, because based on the kind of the partisan nature of the bill, because it was watered down to become bipartisan in the Senate, the fact that we even have a Democrat-led version and led by Ruiz, who is a champion for community health and wants to be a champion for CHW specifically. And that's not from his staff. I talked to him and he said he wants to be a champion. So he wants to hear the voices of CHWs. Ruiz leading this bill means we can probably get a better version of the policy if it's coming from the community, if it's coming from the voices of the advocates and the people who really know it, you all. And so if we can get that bill better from Ruiz's perspective before the end of this year, then what we're really doing is teeing up for next year to try to pass a version that is better than the Senate version, and trying to put that pressure on it. That depends on a lot of things, of course. That's a little bit us hoping that then there's enough votes in the US House to matter next year for that bill, or that there's enough pressure from a strong bill with community support to push for the Senate bill to be made a little bit stronger as well next year. Because essentially every January, the slate wipes clean and they go and look in the kind of graveyard of bills that didn't make it for what can be reintroduced. And if we have something strong on the record now, then we're doing great for next year.
Great, thank you, Justin. Looks like Honey has a question. And then we'll go
What's up, y'all?
Hey, Honey.
How y'all doing? Hey, Darrell. Hi. Justin, thank you so much for that information. That was really helpful. I'm curious, and I don't know if who this question should be directed to. Maybe it's us as a group. Have we ever considered an investment into a lobbyist? What are y'all's thoughts about that?
That's really maybe a question also that I have, as we're starting to create our nonprofit here in California. People are very afraid of the advocacy component, even though that is what we're a home. And, what is it that we can do within a nonprofit? And if there is advocacy like paying a lobbyist, what structures do we need to put in place to protect our nonprofit organizational structures? People want to be involved in advocacy. They want to be writing letters. They want to be doing whatever it takes. I guess that was also my question, was to Justin and perhaps this group. Are there, templates for letters for sure, but also strategies for engagement of the state level associations and local networks to inform them, number one, of what's going on, and number two, to activate them to get involved?
That's awesome. I want to throw in just really quick on the question about what a nonprofit can do, based on our experience. And I'm not an attorney, so I'll give that caveat of the attorneys help figure this out. So one thing that folks always think is that nonprofits under the 501c3 tax exempt status can't lobby, but that's wrong. We can actually lobby. So it depends on your revenue. So for PIH, we're a large enough organization, more than $17 million in revenue per year, So we can lobby with up to $1 million spent on lobbying. We don't even come close. We spend like an eighth of my salary and like half of 2 other team members' salaries, and I don't even think we've broken $100,000. But you know, that's how the legal limit on lobbying works. It does count federal and state, so that's an important piece of it. But everyone has a limit somewhere below that $1 million mark, depending on your revenue. And there's a tax form that you can fill out to report how much you spend on it. If you don't fill that out in lobby, then it's actually up to the IRS to determine if you've been lobbying too much. So it's always better to fill out the form, is essentially the piece. But that's not where things are limited to. There's also grassroots lobbying. So when we ask volunteer members to go and advocate for a bill, that's all legal as well. But it has its own limit, and it's lower than the other limit. So making sure you know your limits based on your organization's size and revenue is really important. The weird thing is these rules exist because of churches. Churches were the first 501c3 nonprofit organizations in the US, and they used to, some religious institutions would try to exercise a lot of lobbying in the US. So they passed these laws to limit the amount that religious institutions could lobby. And that created the way our entire nonprofit system works on that. But the other piece I wanted to throw out there that can be done by state associations, it's a little late in the year for this, but it's totally legal for nonprofit organizations to ask political candidates questions and report the answers to those questions, as long as you ask every candidate in a race what those questions are, or give them the opportunity to answer. You can't rank them, you can't endorse one of them, you can't do anything like that, but you can transparently report their answers back. And so that's something that I always encourage folks to do. Consider doing a candidate questionnaire and putting it out there. It can at least give you some accountability, especially at the state level, to see like who here actually is going to support a state plan amendment. I mean, I know legislators don't actively work on that, but like, you know, to be able to point to who's going to be in the way of the governor doing this, who's going to be on the right side of this, and let voters at least know that information and message it like you would any other message. But yeah, there's special rules around it. You can't have them sign a pledge. You can't have them, you can't rank them, those kind of things. But otherwise, you can ask them whatever you want.
Great, thanks, Justin. That's really helpful. Any other thoughts? Carl, I see your hand up.
Yeah, I want to thank Justin for the whole presentation. It's great, very, very helpful. And the comments, your comments at the end, I've served time in DC, so I'm familiar with a lot of those issues. And some of the things you're talking about are a decision for the board, for the NACHW board to be making, certainly. And it may be that a good investment early on is some legal advice from somebody who specializes in nonprofit tax law. I worked with some great people in DC at Kaplan and Drysdale who really kind of wrote the book on this stuff. But also, you know, there may be an opportunity to invest in someone to advise about advocacy, not someone who's a paid lobbyist, but somebody who can advise NACHW on what we can and should do, and that may be a good investment as well. So thank you.
Thanks, Carl. Any other questions or just, you know, responses, thoughts to this concern and idea about sort of advocacy versus lobbying and how NACHW might be involved, or how state associations might be involved? No? Okay, other questions or thoughts for Justin?
I don't know if this is for Justin. I see something in the chat. But there was a question that we were going to pose, Ashley, related to would people who are here today like NACHW to engage them in things like sign-on letters and call to actions about CHW federal policy? Do we want to talk about that later, or just bring that up as we talk about this topic of activating? What do you think, Ashley?
I mean, I was gonna do it at the end, but we could go ahead and bring up the poll now if we want to.
No,
What's
that's
your
good at the end. That's good. I just
Okay.
want to make sure.
Leave
Yeah.
it to the end. Okay, great.
This was like that natural, organic flow of conversation that led us down that path. Thank you, Ashley. Back to you.
Sure. Yeah. Well, I was just going to ask, Justin, obviously you work on a lot of different policy areas, and we've got just a few minutes left in your segment, and I don't mean to put you on the spot, but are there any other important policy, issues or specific bills that you think that we should be keeping an eye on that might be, really important for CHWs to know about just briefly?
Yes, and actually, thanks for asking this, because I meant to add it to my slides and neglected this. But in our federal budget process, appropriations, as we call it, we're dividing the pie. We have this year some committee report language. Now, it's committee report language isn't law, but it's supposed to guide agencies on how to spend money. That just came out of the U.S. House Labor and Health Committee, or subcommittee. Anyway, but basically this Appropriations Committee has said that when it comes to mental health specifically, we need to work with community health workers on mental health interventions. And that recommendation made it out of the committee. It's made it to the House floor. Markups are done. So they've finished amendments and things like that. And a final vote will happen on that right after they get back at the end of August. So in early September. And that'll be an important one for us to watch, because if it keeps the mention of community health workers in there, then it automatically will mean that SAMHSA and other agencies that work on mental health funding will be directed to send money to community health workers who apply for, like, agencies and organizations that apply for funding. So it will mean new grants. So it'll be important for us to watch, and as of now, I think the language will stay, mostly because of the partisanship and kind of brokenness of our process right now. The Senate will most likely just pass a version of the appropriations bills that the House has already passed without amending or doing anything to them.
Great, thanks. We'll definitely keep an eye on that. Carol, I see your hand up.
Yeah, I'm just wondering how that will work in places like California, where we have two separate certifications for community health workers. We have an existing one for peer support specialists, and the new wording for the community health worker benefit that's just come out excludes peer support specialists. So personally, I'm cross-trained as both, and I know at the grassroots level, it's often the same people who are doing the work, and they may or may not have both credentials or training. We don't have certification at the moment. Understanding is that that will come into being a year from now, 2023. But that we do have this split. And I think the concern is, from CMS perspective, is they don't want double dipping in terms of billing. So there are separate billing codes for peer support specialists and community health workers. So I guess it's just a question perhaps as to how to roll out.
Yeah, unfortunately, I think at least this funding, this legislative stuff, will just roll out in exact same way as the existing billing codes. So the same problem will persist. They'll continue to exclude peer support specialists. Unfortunately, I think, however, having the conversation about how to fix that is critical. So I'm actually hoping Carl has answers in terms of thinking about state plan amendments at least.
Well, I think that's a perfect segue to our next segment, which Carl is going to lead. But Justin, again, thank you so much for being here. We really appreciate your time in assembling all this information and being here today. You're welcome back anytime. We'd love to hear from you again, and we'll probably be in touch So thank you so much. And thanks for sharing your email. I imagine you may get some follow-up questions. So thanks again. So with that, I'm going to turn things over to Carl Rush, who, as many of you know, serves as the policy advisor for NACHW. He's going to be providing some updates on recent Medicaid state plan amendments, as well as some developments in the CHW certification world. And Carl is going to share his screen.
Okay, great. Thank you, Ashley, and Darrell. And can you see my screen now?
Yep, we can see it.
Great, thank you.
Sure.
Okay, so I'm going to pick up where Justin left off, and I know it can be incredibly frustrating to try to make change at the federal level. I would add that I think the Republicans and increasingly the Democrats are saying that more of their energy really needs to be focused at the state level, where change may be more possible in many cases. And it's certainly the case that the issue of Medicaid payment for CHWs, which is on many people's minds right now, can be accomplished, and is being accomplished in a bunch of states, and it is very encouraging. I will say, at least for this administration, that CMS is very open to what the states are proposing. And we've had a flurry of recent state plan amendment proposals approved by CMS with increasingly broad scope. And the general message is I wouldn't call it open season, but it's a great opportunity for states to seize this, with the one caveat, which I think most of you are well aware of, is that Medicaid is not the only answer. Medicaid has a lot of limitations, and among them, the biggest may be the fact that Medicaid spending can only be used to benefit Medicaid beneficiaries. And so there are a lot of people both above and outside of the Medicaid eligibility structure that you would like to serve, that CHWs would like to serve, that Medicaid can't help with. So a real quick review in a few slides of what's going on now. And there is a lot of action, and I spent a lot of my time on this, and I still find it hard to keep up. There are 8 state plan amendments that have specifically been approved, specifically with reference to community health worker services, sometimes defining them as a benefit, which is part of the language that helps you get into the Medicaid system. But and again, this is distinct. I'm not going to be talking about waivers, although there have been a lot of waivers in quite a number of states that are generally for more specific purposes. What we're really talking about with the state plan amendment is a more sweeping definition of CHW services that can be provided in a lot of different situations. So the way the state plan amendment process works is that the states are basically getting approval for being able to pay for CHWs generally by using a fee for service, which is really what reimbursement refers to when we talk about Medicaid, a fee for service payment, and they can define a rate of payment for those fee for services approaches. But the actual implementation may go through other systems. In other words, in many states, most of the population is covered by managed care organizations. They receive benefits through managed care organizations. And the state, after the state plan amendment has been approved, can work out with those health plans how they are going to pay for those services. But the state plan amendment itself may simply specify fee for service. Part of the good news of what's happening is that the more recent proposals have expanded the view of what CHW's services will be, or activities will be covered. You note I've highlighted Minnesota here, which was the pioneering state in this field in 2008. And they really had limited initially CHW services covered to essentially patient education. That is still part of or one of the provisions that other states have used, but they have added a number of other provisions. The main categories they have included are health promotion and coaching, and as general categories, health promotion and coaching and care coordination. And that can be a sensitive topic. So some states have used different language to avoid raising alarm among folks like nurses and social workers who do case management. And that will always be a little bit of a sensitive issue. So care coordination or resource coordination is another category that is often included in these proposals now, which really opens up a lot more of what CHWs are capable of doing and can really contribute to their community. There was a rule change to Medicaid in 2014, allowing non-licensed individuals to provide preventive services. Nothing much happened with that for at least 5 or 6 years. That is increasingly the rule that states are using to as the authority for what they propose to do. Interesting though is that most states, the recent states, are using the same billing code that Minnesota used in their SPA, which was authorized in 2008, which is fascinating to me. But it may be Indiana was the first one to do that. They essentially copied and pasted what Minnesota had done, and the philosophy seems to be in some of these states that if it ain't broke, don't fix it. If we know CMS will approve it, let's just do what Minnesota did. So why is this important? I think, and this is where we need to talk about engaging CHW leaders in the process of policy formation around these state plan amendments, because, and I really try to emphasize this strongly, that there are a lot of aspects of a Medicaid state plan amendment, depending on the choices that the state makes. These aspects of the plan can have material effect on the practice of CHWs. I'm going to run through these real quickly, but I want to say this is both part of the justification for a webinar series that we've started offering to states, to CHW leaders in the states, which is available free, but we're calling it Medicaid 101, which is intended to give CHW leaders the background on the inner workings of Medicaid in order for them to feel more comfortable being at the table as some of these decisions will be made. And so this is very quickly what some of the categories of things are. And I think you can see why CHW should be concerned about what choices the state makes in these areas. What services will be covered? We would like for Medicaid cover as broad a range of the scope of practice of CHWs as they can. There are certain things clearly they can't cover that it's not worth fighting for those things, but there are a lot more things than health education clearly that CHWs can do. Most states have a limitation on the amount of time or amount of services that are billable for an individual client or recipient, units of service per day, per month, per year. And I think some of those concerns are misplaced. Rhode Island's state plan amendment does not impose a limit on the units of billable service. If they start to see signs of potential abuse of that, they will investigate. But right now, they're not concerned about that. The hourly rate of pay, I think the general consensus is that rates are too low. That's no surprise. Just about anybody who gets Medicaid reimbursement feels that the rates are too low, even physicians in hospitals. And a surprisingly important one is what settings will Medicaid pay for CHW services? Only in the community, only in the clinic, during home visits. The states have come down in different ways on that, and different interest groups have imposed their point of view in terms of what CHW should do and should not do. So the CHWs need to be at the table talking about that issue. The systems that are in place require that someone authorize or order or recommend that CHW services be offered to a Medicaid recipient. In the case of some of the sections of Medicaid regs, one of those, a licensed clinician, for example, must supervise the CHW. It depends on what authority the state chooses to authorize that payment. And so there are a lot of opportunities for that, and states have found good ways to respond to it. So an order for CHW services is like ordering any other medical service. It requires a diagnosis. It requires a description of who will provide it and who will supervise and that sort of thing. But we found in states like Minnesota that they can get away with a physician, for example, writing what they call a standing order, which says for a patient in these circumstances, CHW services are authorized or ordered. And you don't have to go back to a specific physician or other professional to authorize each individual referral. And then a big one, since so many CHWs are employed in community-based organizations, is what is the state going to do to engage with CBOs so that they can participate? And this is a struggle, particularly for smaller organizations. We've discussed this in other contexts. So these are some of the issues that are really important that CHWs weigh in on when your state considers the state plan amendment. So some of the ones that we're looking at have interesting features. I'm going to run through these real quickly. Rhode Island, I've already mentioned, they have the broadest range of CHWs covered. They have a concept called collateral services, where the CHW can provide those services without being physically in the presence of the patient or the recipient, which is an important concept. They recognize the importance of a broad range. Most states require something like a diagnosis of a chronic condition in order to justify CHW services. Rhode Island includes things like 2 hospitalizations or 1 emergency department visit as justifying CHW services. And that's kind of a breakthrough. But most importantly, and this is kind of revolutionary, that they have said that the recipients or the patient's own declaration that they need the assistance of a CHW is enough to consider CHW services medically necessary. That's the crucial test in Medicaid, that they can only provide services that are medically necessary. So those are big breakthroughs. Louisiana, one of the most recent ones, was approved back in May. Their SPA mainly relies on working through the Medicaid health plans, the managed care organizations. And it is likely that 2 of the states that are at early stages, but developing, heading towards development of SPA, being Virginia and South Carolina, they've already declared that they really want to rely heavily on the health plans. And so in other states, they may engage the health plans, but they are not part of the design of the SPA from the beginning. Another interesting part about Louisiana SPA is that they are going to allow federally qualified health centers, who are usually paid through a very different system called a prospective payment system. They can bill for CHW services separately from that whole system. And one reason is that in the prospective payment system, an encounter that is only with a CHW is not considered a billable encounter. So this will allow federally qualified health centers to bill separately for CHW services. Interestingly, and I'm not sure why yet, I'm hoping to find out, the billing for federally qualified health centers will use different billing codes from other providers or CHW employers. And that's a really interesting observation. We'll find out really what it means later on. Minnesota, of course, is the grandmother or grandfather of all of these spas from 2008. They've learned some interesting ways of coping. Submitting a claim for Medicaid reimbursement requires that you state the diagnosis. That does not have to be the patient's primary diagnosis. And in fact, they are increasingly in Minnesota accepting diagnosis codes called Z codes, which are indicators of social determinants of health or needs that are defined as social determinants. And that is an important breakthrough. I understand this is at this point hearsay, but that it was set up in Minnesota for providers, employers of CHWs to bill the state directly, but they are now finding that those organizations, if they have a contract with a health plan, a Medicaid health plan, that they can bill the health plan rather than the state. But importantly, that those providers can negotiate a higher rate than the state pays with that health plan, which is just fascinating and indicates how supportive the health plans are, I think, of the CHW efforts. The average billing rate, and one of the reasons all this stuff is being done by fee for service, is most states would like to use an alternative payment method like value-based payment or per member per month, what they call capitation. They would like to use these other methods, but they don't have enough data to calculate rates for those other methods. So they're authorizing fee for service to start with so they can get some experience on utilization and spending and that sort of thing. And so most of the states up to this point have been around maybe a little under $50 an hour or the equivalent. And it's interesting that a couple of states have come in lower than that. And I'm interested in finding out more about why they decided to go lower than that. But Louisiana, as I say, recently approved. South Dakota was a couple of years ago, but they are below the national norms. So this may cause some stress. I am concerned personally that in states like this, that a lot of folks will simply not bother because they can't get enough in terms of reimbursement to really cover the actual cost. The reason for that, of course, as we all know, is that CHWs need to spend a lot of time with community members developing relationships. And that time that they spend is not considered providing service, so it's not billable. And what many states have recognized is they need to include enough in their rate paid to the employer that the employer can also cover some of those non-billable hours. The rate also needs to cover things like supervision. And you can't just simply pay for the salary of the CHW without covering the supervision as well. So that's why these rates are not what the CHW gets paid. It's what the employer gets paid. So these are important features to be considered if your state is thinking about going for a state plan amendment. Another interesting, very recent development is that California, whose SPA has not yet been approved, and Massachusetts plan to change to paying per member per month, like paying an insurance company or like paying a health plan, per member per month or capitation payments rather than claims for each individual service from primary care providers. In the case of Massachusetts, it will apply to all primary care providers. In California, it's been proposed by the governor to apply to the federally qualified health centers only. And it is explicitly described for those health centers as giving them the flexibility to pay for CHW contacts with their patients, their members. which they can't do right now. And so that is a big opportunity. I am going to, by the way, I was meaning to do this earlier. I'm going to drop into the chat my my email address and a link, which I'll come back to in a second, to our document resource center. So please, if you're interested in further conversation, we will have, I think, opportunity for a little discussion in a little bit. But if you are interested in further conversation, we can do so offline. So I was also asked to talk a little bit about what's happening with certification. There has not been much sort of broadly happening that's new with state certification of CHWs. There are some interesting things, though. This is interactive with sorry, the enaction of Medicaid payment for CHWs, because the state needs to establish qualifications for CHWs who are going to be paid by Medicaid. And that is totally understandable, but it creates some interesting dynamics. So there are about 20 states that have individual certification of CHWs. 3 of the states that have state plan amendments for Medicaid do not have certification, but Medicaid in those states does require standard qualifications, which are defined by Medicaid. And that's one of the dilemmas here, because if you don't tell them what you want those qualifications to be, Medicaid is going to decide what they want the qualifications to be. And well, hopefully that'll be an inclusive process. But one of the things that has been a recurring issue, I'm just going to spend a little more time on this one, is that some states feel they need to have a background check, criminal background check requirement. And I did some digging on this for at the request of the Arkansas CHW Commission, because they're considering certification now. And in general, I told them that I personally do not recommend that they include a background check requirement for a number of reasons, including the fact that most employers do their own anyway. But less than half of these 20 states have a background check requirement. And of those, several states actually allow for exceptions for review of mitigating circumstances, which would allow people, even if they have a negative background check, that they can still become certified. And for example, and I think it's Nevada, which was just approved last week, the certification is not required. The background check is not required for certification, but employers are advised that they may want to conduct their own background check, which is kind of different from what other states normally do. South Dakota does not itself require a background check for certification, but if a CHW wants to be paid under Medicaid, or their employer wants to pay them under Medicaid, then they are required to undergo a background check. So there are all kinds of variations on this. It's important to remind states and to keep in mind ourselves that federal policy does not require the states, in order to submit a state plan amendment for Medicaid, does not require the states to have certification, nor does it require states to have a background check requirement. And so those decisions are entirely on the state. It's their responsibility as to whether they're going to do it. Very briefly, Massachusetts and Oregon are 2 of the states that have a post background check review to consider mitigating circumstances. These provisions have been hotly debated in those states. Oregon considers what they call a weighted process, considering supporting documents like affidavits or testimonials or whatever that can be submitted to say that the individual should still be certified. Massachusetts, and there may have been more since I got this information, but Massachusetts has had only 2 examples of adverse background check reports. And in both cases, the report requirement was waived. The individuals were allowed to become certified. And one of the notes I want to make on this, which came up in my review of this, not everybody thinks of this immediately, but something like 90% of community health workers are female. And the incarceration for females, even women of color, is starkly lower than it is for males. And so frankly, you're going to have fewer circumstances of female candidates for certification who have negative background checks. So I just want people to absorb that and say this may not be, excuse me, as horrendous an issue. It is certainly a significant one and needs attention, but that's important. If you are going to have, as these states like Massachusetts and Oregon have, review of individual situations, you need to establish clear guidelines, and you're going to need staffing to manage this stuff. These decisions in terms of reviewing individual situations should not be done arbitrarily. There really need to be standards that guide that process. So that's a quick review of some of what's happening in certification. I said I would mention, excuse me, the Document Resource Center. The link was in the post that I just shared in the chat. That is for you and your organizations to look at what other states have done in the development of policies. If you have not already used it, we encourage you to go to it. It's on the NACHW website. It is open to non-members as well as members. And it has over 1,000 documents on the process that states have gone through in developing policies and what they came up with. So I don't know if we have time for questions at this point, but as I said, I'd be happy to respond to individuals by email later time. But that's my story, and I'm sticking to it. And I think you have to shut down my sharing. For some reason, my computer does not have a stop share button.
All right, great. Well, thank you so much, Carl. That was fantastic. Lots of really, really important and up-to-date information. We appreciate that. And we are a little low on time. So why don't we maybe just take one question and then move on to the rest. There's a question in the chat. Wesley Turner is asking if there's any information on the new legislation that was passed in Michigan last week that is leaning towards developing a state plan amendment or an 1115 waiver.
I am not familiar with that specific legislation yet. I am in communication with the Michigan CHW Alliance, and I know that they are gearing up to try to work with the state. They have had a provision where their Medicaid health plans have been required to offer CHW services. That has not gone terribly well, mainly because there are no guidelines or policies around what those services must entail. And that's a long story short, that the CHWs and their advocates in Michigan are very disappointed with what at least some of the health plans have done under that provision. So it's not typical of what other states have done. So they do see an opportunity in this new legislation, but I don't have more details on it. I'm sorry about that.
All right, fantastic. Well, thank you so much for all that great information, Carl. Really, really appreciate it. And certainly as we find out any more information about what's going on in Michigan as well as other states, we will be certain to share that. So with that, we're going to go ahead and move on to the next piece of our agenda. So I'm going to share my screen again and hope for the best. Give me just one second here. All right. Okay, can everybody see this little piece? It says request for NACHW policy review. Yep, okay, great. So I will go through this very, very, very briefly, but just wanted to make sure that everybody is aware that this exists. So sometimes NACHW gets requests to review or endorse or provide comment on various things like position statements, policy papers, research papers, things like that. So we have created a form that is available on the website. When we go back to the PowerPoint slides, you'll be able to see the link to this, but this is on the policy page of the NACHW website. But basically when anybody wants to make a request, so if you, your association, somebody you work with that you know of, wants to make a request for NACHW to review a policy and provide an endorsement or comments or things like that, you can go to this page. So I'll show you just briefly what is on here. This is actually the last page, so we'll go back. I filled this in with just some general answers, but so it's going to ask you, you know, sort of the source of the request, so the name of the person completing this form, your phone number. I promise that is not my phone number. Whether you're a CHW or an ally, what your NACHW membership type is, if any. The name of the organization making the request, a little bit about the organization type, whether the organization has a website, which helps NACHW take a look at that website, get a better sense of what the organization is. So just some sort of background questions. And then there's a request for information about, you know, why people are making this request in the first place. So brief summary of the reason for the request, how soon NACHW's input is needed, with a note that there should be at least 10 business days. Definitely sometimes we get requests where it's like, hey, we need your answer tomorrow. And oftentimes that's difficult. And then sort of which of the following does your request involve? So are you asking for an endorsement like a sign-on and use of the NACHW logo? Are you asking for contribution or co-authorship on something? Are they asking just for general advisement, like, you know, NACHW would be offering general recommendations, promotion, awareness raising, or advocacy, or participation in, you know, say something like a coalition or roundtable or something like that. So this is the form. So again, just wanted to make sure that everybody is aware of this. The big piece also is at the end of this form, there's a little add file button. So if there's, you know, again, something that is like a position paper or something very specific that should be reviewed, that can be attached there. So if you, a network that you're affiliated with, you know, any advocacy association you might be working with would like NACHW to review something, please use this form, and then it will go to NACHW, and depending on the nature of the request, the timeline, it will go to NACHW staff and or the policy committee to review. So that's just a brief overview. Any questions I can answer about that at all?
Ashley, in what cases would NACHW provide an endorsement as opposed to maybe just like words of support or, you know, supportive language around a document?
I think it really depends. I mean, there are some considerations involved, things like, you know, what is the document, right? What is being requested? To what degree were CHWs involved in developing the request? You know, what are the potential implications for the workforce? We have sort of a set of criteria that can be reviewed when these requests come in. I hope that helps. Other thoughts, questions about this? Okay, great. I will then, again, so this is on the policy page of NACHW, which is right here. It's kind of down towards the end. So you can just click right on this request for NACHW policy review form. So if you need that, it is there. The second to last thing we want to do today, or maybe third to last, is just want to talk about some resources that are available. We often hear similar questions about interest in more information about things like Medicaid information that Carl just presented, more information about certification. So the first thing that I want to do is just point folks to the existing resources that we already have. A lot of the issues that people are experiencing in their states are issues that other people are experiencing in other states, and we've tried to address to some degree. So first and foremost, consult that document resource center that Carl just mentioned. It's super helpful. Another resource that we have is the NACHW YouTube channel with tons and tons of recorded webinars on here. So you can literally just you can Google National Association of Community Health Workers YouTube, and the channel will come up. When we go back to the slides, there's also a link in there, but feel free to use this as a resource. There's lots of great information here about things like the NACHW Policy Platform. There's various training. So, here's one on diabetes. We have questions sometimes about certification, and somewhere on here, there is this one, a webinar about certification from a study that we did a while ago. There's information here about the CHW Core Consensus Project, often known as C3. So if there's some piece of information that you're sort of dying to have or want to have more information about, take a look through the YouTube channel, and oftentimes there is some information there. So I'll mention that. Let me stop the share and go back to my slides real quick. Oops, that's the wrong one, sorry. All right, here we go. Sorry about that. Okay, so going back just a bit, just want to show you in the slides that the little tiny URL for the policy review request link is in there. Document Resource Center link to the YouTube channel is right here. One other resource that might be helpful is the Envision team has this landing page. It's not really an official website, but there are a lot of great resources there. Envision is one of the groups that's funded by the CDC Community Health Workers for COVID Response and Resilient Communities grants. So they are focused, and I don't know why I'm saying they, it's we, I'm involved in that, but we are focused on supporting the state and local tribal and territorial health departments that have received money through the CDC 2109 program. So some good resources there. So please feel free to check that out as well. All right, with that, we are going to do some quick announcements. I'm going to turn it over to Darrell if he is still around.
Yes, man. Hey, everybody. I know there's a lot of events going on. I know the Spectrum CHW conference in Michigan is coming up on August 18th. I didn't get that link quickly, but I hope folks know about that. But there's some big national meetings coming up on us like tomorrow. One of them is Unity 2022, and as you know, the Unity torch has been passed over to NACHW since 2019, 2020. And so August 3rd and 4th, there's a virtual Unity conference. The agenda is available. If you haven't registered, please take a look. I'm pretty sure it's still free to CHW. And you'll see the rates there for others. Please take a look at that link. Also, many of us have been coming together for decades at Unity, but also at the American Public Health Annual Meeting. This year is the 150th celebration of APHA. It's the event happening in Boston, November 6th through the 9th. And just like with Unity, all the abstracts have already been put in. And pretty soon we'll be able to see a schedule for APHA and meeting. And we always tell people this is an in-person meeting. They may have some hybrid sessions, but it's in person, and we urge people to get their rooms and register early if you can, to save money by registering early. Ashley talked about the 2110. I think Carol even mentioned CPR earlier, but I put the link in for that. That's a big project. Pretty much every state, many tribal nations are involved, and so we urge people to continue to get familiar with the community health workers for COVID resilient communities, also known as the CPR project. So many of us who run this and some of our colleagues. This next meeting will be October the 12th for this meeting, and we urge people to continue to give us inputs. As I mentioned as we started this call, it's critical. Each meeting, we review what the ask is out in the field, in the world, and what's not from it. We designed these just for that. So Carl's talk, Justin's talk was a direct response, asking for more details. And that's it. I'll turn the microphone back over to Ashley. I think that's all I have. Maybe others may have other announcements time to look at the chat. But back to you, Ashley.
Great, thank you, Darrell. The last thing that we have for y'all today is just a quick poll. Darrell was mentioning earlier that we want to hear a little bit more from y'all about how we can best engage you and sort of what some of your needs are. So Carla, if you have a moment, if you could launch that poll, that would be great. And there we go. So just a couple quick questions. If you could take a moment to fill that out, would be great. All right, so we've got a whopping about 2.5 minutes left before we are finished. We have our email addresses up here in case anybody needs to reach out to us. We would always love to hear from you. But I will stop sharing my screen and ask if anybody has any questions, thoughts, concerns, or anything that we want to discuss before we sign off. All right, hearing none. Well, we can go ahead and finish up for the day. Again, thank you to Justin Mendoza. It looks like he had to sign off already, but we're grateful to him. And thank you very much to Carl for providing fantastic information. Thank you all for taking the time out of your very busy days to be here, for asking great questions and being engaged. And we look forward to seeing you again soon. Keep up all the fantastic work that you're doing in your communities. And yeah, we look forward to seeing y'all again soon. Take care, everybody. Be safe.